It's my pleasure now to introduce our moderator, Eileen Korey. She's currently at the University of Akron, where she's been since November 2011. She serves as Associate Vice President and Chief Communications Officer. She came to the university following nearly 20 years as Senior Communications Counsel in the healthcare industry, as advisor to the leadership at the Metro Health System and University Hospitals of Cleveland. She was responsible for strategic communication planning and execution, reputation and brand management, crisis communications, media relations, integrated marketing communications, and advertising strategies. Prior to her career in organizational communications, she developed the reputation of one of Cleveland's leading reporters and was inducted, in fact, into the Journalism Hall of Fame by the Press Club of Cleveland. She's worked in print, radio, and television, and may be best remembered as the medical reporter for WKYC-TV, our NBC affiliate here in Cleveland, where she was on the air from 1984 to 1992, and during that time she earned 6 Emmys for reporting. Currently, she serves on the board of the Susan G. Komen for the Cure Northeastern Ohio affiliate. She's on the board of the Cleveland Jewish News, as well as the Western Reserve Public Media. It's my pleasure to introduce to you Eileen Korey.
Thank you for that. Actually, I have to point out that in the audience tonight is the man who first hired me at University Hospitals. I didn't tell you I was going to do this. Ori Jacobs was Executive Vice President at University Hospitals at the time. This followed my doing a 30-some-odd part series on colon cancer, on colorectal cancer, that University Hospitals sponsored at that point in time, in the old days when the HemoCult test was really widespread and all those campaigns. I think Ori saw the creativity with which I attempted to tell the HemoCult colon cancer story at least 39 times. And sitting next to Ori is my husband, who got into calling me, excuse me, we're going to start out very informally, the colon queen of Cleveland. There were other names, by the way, but I won't say them here. So, whether you call it Obamacare or Affordable Care or the Affordable Care Act, it is transforming the healthcare landscape here in Cleveland and around the country. And given that healthcare is still our largest employer, it's impacting all of our lives, not just the ones who consume healthcare, and all of us do, but all of the folks who work in healthcare or related industries like insurance. Most of the attention, of course, recently has been paid to what some might call the debacle of the rollout, though I think the IT folks probably took the biggest hit on that one. Canceled policies and what others have called premium shock. But what's behind all those headlines? What's happening in the daily delivery of healthcare? When you call up and you want an appointment, when you go to your physician, when you're hospitalized, when you try to get an insurance company to pay for it, what's happening in the mundane day-to-day delivery of healthcare? That's what we really want to talk about. What have we noticed that has changed? What have we not noticed that perhaps has changed or will change? And will we end up regretting what some have called a transformation that was supposed to be a reformation? Or will we feel better about our healthcare reform because we simply feel healthier? Those are some of the questions that I want this panel to address. And I'm going to do the ground rules just for a second, okay? Though I will ask the questions, you will have an opportunity. Please go ahead. If you have a question, raise your hand. There are going to be all kinds of cards set out so that you can write down your question, because I may miss what is on your mind. So don't wait till the end. Let's not be very formal. I did set out a series of questions that I did not really give to them, actually. I want to catch some of them off guard, which I probably can't. At the same time, I don't want to ask the same question to all 4 of our professionals here. So I might target the question to one, and then the ground rules for you guys is I want you to step on each other, i.e. let them finish a sentence, but if you've got something thoughtful to add, please do, because I can't read minds. Was a reporter, but can't read minds. So I want to introduce all of you. I did a little bit of internet searching today on some of you that I don't know very well. Sitting next to me is Dr. Eric Bieber, who's at my old employer of University Hospitals, but wasn't there when I was there, and so welcome. Now president of Community Hospitals West Region. And for those of you, that means across the bridge, okay? I happen to live there. So that means all of the western facilities in Cuyahoga County, including now Parma, which is the newest facility. And Eric is also president of the Accountable Care Organization of University Hospitals and a pivotal player in the formation of what is now 5 accountable care organizations as part of the UH system. A recent article in Crane's Cleveland Business said that UH has been especially aggressive in its growth in ACOs, now including, correct me if I'm wrong, 170,000 individuals who are self-insured, commercially insured, Medicare, Medicaid coverage. And you recently signed deals with Cigna and United Healthcare to build their ACOs, their accountable care organizations. Dr. Bieber, by the way, I always like to find out how these people came this far. By training, he's a reproductive endocrinologist, means he makes babies and delivers them, or did, used to. Okay,
A long time.
and therefore he got out of that, went to Harvard, got his healthcare management degree so that he could get out of the 24/7 life of delivering babies, right?
Not exactly.
Not exactly, okay. Change the subject.
But it sounds good.
There we go. Television will do that for you. Marty Hauser is an old friend who I've been in the healthcare world with for a very, very long time. You are Chief Executive Officer of SummaCare, one of the region's fastest growing health carriers. Also serves as Chief Government Relations still, so that's a big, complex job. Back in 1990, did I get this right, when you were president of Akron City Health System, you oversaw the creation of what was an innovative managed care program called SummaCare. Today, SummaCare and its affiliated divisions, am I right here, serve 240,000 members with clients in 5 states. I don't think anybody realizes how big you guys are. Recently, I heard Marty speak of the evolution of the sick care system into the health care system and a new sense of morality in the insurance industry. And I hope you're going to talk about that tonight. Dr. Akram Boutros, who came to Metro after I left, so I did not have the privilege of working for him, became president and chief executive officer at Metro Health in June of last year, with more than 20 years of leadership experience at large community hospitals, specialty hospitals, academic medical centers, and he came here from my hometown of New York, Long Island, New York City, et cetera, et cetera. He's an internist by training, a graduate of Harvard Business School's Advanced Management Program, and I found this interesting, a published author in areas as diverse as trust and innovation. In a recent article in Cleveland Magazine, Akram is quoted as saying, quote, "Healthcare is a business, medicine is a science, but what we're talking about is healing." I love that. Okay. Dr. David Longworth at the Cleveland Clinic, chair of the Medicine Institute and associate chief of staff for clinical integration development still. Also currently leading the team for the clinic's value-based care initiative. Your clinical concentrations, also interesting, internal medicine and infectious disease. In an article in Forbes on accountable care organizations, Dr. Longworth is quoted as saying, "We have to get costs under control irrespective of the payment model. Hospitals and other providers need to better understand how we can take waste and cost out of the system, and we need to improve the quality of our care. We are all of us working to develop ways to better coordinate care for populations of patients, deliver value for patients, because it's the right thing to do for the patients and for the country." So I'm going to start with another quote, and that is from Toby Cosgrove. I promised I would do this in the article in the Cleveland Jewish News. Toby was interviewed by Channel 3, and I heard this quote, and it sort of stopped me dead. And he talked about the Affordable Care Act as being a huge, huge social experiment. Now, I have to tell you, when I heard it, I remembered later him saying, "a great social experiment." That was what I thought was the quote. I saw him at a meeting, and I said, "Toby, I'm going to quote you. I remember your quote being that it's a great social experiment." And Toby said, "No, I didn't say great. I said huge." Ooh, okay, that's kind of interesting. So, the reason he said that was because it's the biggest social experiment ever done in the United States since the New Deal, because it affects 100% of the people and it is 18% of the gross domestic product. So it may not be great, but it's huge, depending upon your political perspective, I suppose. And I'm looking at you, David, because I warned you, you work for him.
Indeed.
I figured you would want to take on that quote. How do you react?
Of course. Well, my reactions are several. First, Toby is a visionary thinker who challenges us frequently to think creatively and innovatively. And so I think that there's some truth to that. The magnitude of what this act tries to do in terms of redefining and reshaping how we think about the healthcare delivery system, moving towards well care, as was suggested, and away simply from fee-for-service care that incentivizes doing things that may not be necessary. So I do think that it is a potentially transformational piece of legislation. Huge, I think, refers to the fact that we currently consume about 18% of our gross domestic product on health care, and that number continues to rise, although the rate of rise has slowed. And it does involve potentially all of the people in this country, whether or not you are able to get Medicaid in states where that expansion is not going to occur. So I do think that the magnitude of the impact of this legislation is potentially huge. And I think we're going to see how...
assume you would all agree, whether it's huge or great.
I wouldn't agree that it's an experiment.
Go ahead.
I think we've been experimenting for the last 30 years and we've failed miserably. We don't have a chance to experiment anymore. We're going to bankrupt the country and bankrupt the economy if we don't figure it out this time. We tried in the 60s, we tried in the 70s, we tried Clinton Care, we've tried all these things, and I agree with the concept. I don't agree that it's an experiment. I think this has got to be the real thing. We really have to make it work this time.
Wonderful transition, and I love the fact that you've taken this on already, Marty. Thank you. All of us who've been in healthcare, particularly in Cleveland for many, many years, have seen changes or heard about changes. It's a competitive environment. We've heard we're over hospital bed. How do we think this change is perhaps already showing signs of positive change where others in the past have not? Another question related to that. We talked about managed care, 20 years ago? 15? So is this just managed care we fabricated? People thought managed care failed. So maybe the insurance guy should start with that.
Yeah, so I'm feeling a little overwhelmed here. Not only do I have 3 doctors, I'm the only insurance person here, so Joni, you're going to have to help me. I lived, as most of these gentlemen did, through the age of managed care in the 70s and 80s, the HMOs, PPOs, EIEIOs, whatever else we could come up with. And the reality is, if you look back then, and I will share with you that I'm very biased because I run a provider-owned health plan that is linked to a health system whose objectives is that the provider-owned plan supports the health system in the transformation of care. But back when we tried managed care the first time, I believe the reason it failed is because there weren't the right incentives. We didn't have the data and informatics, and we allowed the insurance companies to take the lead, partly because, quite frankly, and I'll be interested in the reaction of my friends up here, we didn't exercise our responsibility as providers of care to take the lead in transforming care. And so we let the insurance companies do it, and yet we didn't arm the doctors and hospitals with the tools and the data and the informatics that they needed. The difference now is that we're letting doctors and hospitals through accountable care organizations and others take the lead, and the insurance companies are doing what they should be doing, which is supporting the transformation of healthcare instead of leading it.
So,
Go for it.
so one is I don't think I was old enough to remember managed care. I think Marty's absolutely right in that this was a business-driven model for curtailing care, for reducing the amount of care that gets delivered. It was not a clinical innovation or a clinically designed program to provide better outcomes. What we were measuring was how many units of service or care we were delivering, and that's all we wanted to do. The difference today with the Affordable Care Act and the accountability that goes with it, is that's not the end result. The end result and what we're looking for is better outcomes. Better outcomes that are at lower cost with higher patient satisfaction. So that's the triple aim. So I think today we understand what we need to move towards, and we do have a lot more data and deeper understanding of how to do this. And finally, just a criticism of physicians in the past is that we were all lone rangers. We were trained to be lone rangers. We didn't even have tantos. We were just alone providing services. No one could tell us what to do. It was very hard to get us information, and we practiced medicine the way we wanted to practice medicine. We have significantly transformed that, and most physicians understand that it is team-based care that's going to get us the best results possible. So it is folks supporting each other for the outcome, not with a single captain that runs the entire show.
I know you wanted to say something. You brought up a bunch of questions I won't forget. Go ahead, Eric.
Yeah, so the term managed care, if we went around the room right now and asked you what you thought about that, I mean, uniformly, I think everybody would probably have a negative impression of the word. And what I would say is that's unfortunate. And in answer to your question, is what we're talking about today some slight variation or iteration of managed care? I think what you heard the two of them say and what I'll say is no. It's not the same. Now, by the way, there's nothing really wrong with managing care. If it's my family members, you want it to be managed really well. I think what we didn't do in the times, and I was in Chicago during the time where managed care was quite prominent and actually remained prominent there. It was very focused, as Dr. Boutros said, on finances. And I think what you hear us talking about today when we get to talking about accountable care organizations, it's about connecting the dots. And the management's management over periods of wellness, over periods of chronic illness, over periods of acute illness, over end of life. And it's not management in the form that people thought about it with a doctor telling somebody what to do. It's about well-informed patients who understand their choices and their options, and they and their families can participate in the choices, and that ends up better care. So managed care, unfortunately, took on this pejorative term that probably isn't fair. So from my standpoint, you just, leave it, throw it in the basket, and, it's not worth talking about it much anymore. I think the question for all of us today is, what do we want care to look like? If it's you or your family members, we now have an opportunity with the change that's going on in medicine for us to create something different. So the social experiment, that's the Affordable Care Act, I agree with Marty. We needed to do something different. But let's be clear, this is a start to something that's going to go on the rest of the days that I'm walking on the planet. It'll have to. It has to get better for each of us and for our families.
If I recall, thrown into managed care was the term of rationed care, and that also became so negative at that point in time.
Right. So the question is that politicization or is that reality? And again, the challenge with it, and as the conversation here was framed, and I had to decide, do I really want to come and do this tonight? I kind of like this guy, so I thought, well, what the heck? I'll sit next to Mr. Hauser, the insurance guy.
You take a shower afterwards.
It's the challenge is it is politicized, and so I think part of what you have to do is extract out, what's politics and what's people trying to position for political offices. Nobody here that I know is running for political office.
Not yet.
And what's, well, I'll vote for you, Adam. God bless you. And what's really about care and care delivery and medicine? And I'd argue it's two different things. So I hope what we get out tonight is the part that's the political part and the part that's how do we drive healthcare forward? Because it's the latter that I think most of us are most interested in.
And when we talk about rationing, we really need to also think about the American psyche. And the American psyche is more is better, period. Doesn't matter what it is. Bigger cars are better. Bigger homes are better. The more money you spend on clothes is better. The fancier the restaurant is better. So that is what the psyche of the patient as well is. Give me more tests means I am getting better care. So one of the things that we have to work on is really dismantling this notion from more meaning better. Because frankly, in healthcare, more often means not as good. You stay longer in the hospital, you have a much greater chance of infection. You stay longer in the hospital, you have more chance that you're going to go to a nursing home and have to get rehabilitation. So there are a lot of reasons why more isn't better in healthcare.
So as one tries to create a more accountable system, and I don't mean rationed, but more rational system, the question is, has the payment model kept up? So, you know, we've moved from talking about always fee for service to a medical home, to some kind of management, to accountability. But if I understand things correctly, most of you guys are still getting paid for each procedure delivered and every test and day in hospital.
Right, we're still nipping at the edges. So let's be clear. We live in a world that pays for acute episodic care. That's the system as we've designed it. And so the results we're getting are absolutely perfectly set up for that. So I think you see reform in part, nipping at the edges, in ACOs with, you know, a drive towards value. So you're talk about, you know, value. It's, you know, how do you drive quality while you're driving efficiency? So in, you know, in the managed care world of long ago, it was a lot about dollars. Well, I mean, dollars are relevant. You don't want to spend more than you need to spend for whatever it is you need to have done. But you need to know that the quality is high or getting better. You can't have one at the expense of the other. And, you know, the good news is, and what we've learned, you don't have to. You can actually do both of these at the same time. But I think, you know, your question about, you know, payment reform, bundled payments, you know, we're just beginning this. This is all nascent. You know, this isn't the way that most health systems are operating today. You know, we're at the very beginning of what will probably be a 10 to 20 year evolution.
So if I could jump in, I think Eric's right on spot, because we, the insurance companies and the federal government through Medicare and Medicaid today, pay doctors and hospitals for sick care. They pay them when people get sick. They pay them for the things they do. It's episodic. We oftentimes use the phrase widget production. It's the ultimate field of dreams. You know, if we build it, they will come. The more we do, the more we get paid. We don't pay hospitals and doctors for health care, and we don't pay them to keep you and me healthy. We're moving there. It's going to take a while to move there, but we've also got have to get the insurance companies to recognize that in order to move that dial to health care, the insurance companies have to create payment models that pay the doctors and hospitals to do it. And I don't envy my colleagues up here, because they have 1 foot in one canoe and 1 foot in another canoe, because they get paid by most insurance companies to do more things. So you want to do more things so you can get paid more. And then you have us conceptually talking about being paid with bundled payments and being paid for keeping people healthy, and those canoes have to function simultaneously until we ultimately get to where we need to go. And as Eric said, it's going to take a while.
Wow, how is that playing out? One of our physicians here, please, so that the folks out here in the audience, if they go to the Cleveland Clinic, if they go to Metro, if they go to UH, where are they actually seeing or feeling any of this play out?
So it depends. It depends on your current situation and perhaps where you go. But we are in the midst of fundamentally transforming our care delivery model to make value that is improving quality and lowering cost, really at the core of what we do and how we deliver care. And we're working on doing that in the primary care space and in the specialty space. But to the points that have been made, we're at the beginning of this journey. And so the people right now who are most apt, if you go to your primary care physician, to feel a difference are people who have chronic diseases, people who are in and out of hospitals, because we are now beginning to much more aggressively try to proactively, and not episodically, but proactively across the continuum manage their care. And so, yes, those people are beginning to feel the difference. The young, healthy 25-year-old probably is not seeing a whole lot of difference if they're coming today, but over time, I love the comment that Marty made that we have to move to well care, and that's going to take time to scale that across the entire population.
Has this approach actually hit sort of the insured middle class, upper middle class type folks? So for example, I worked at Metro for a long time, and Metro bore the brunt of trying to treat those in the world who were not insured, not well insured. Of course, there were many of us who were insured and still go to Metro. But I remember us beginning to institute medical homes and that version of accountable care early on, because you're dealing with a population with a lot of chronic disease. And boy, if they were coming into the emergency room, it just cost you much more. So I remember that. But is it actually hitting sort of the suburban university hospital-based Westlake Clinic Center or Parma or the clinic?
So if you look at the data from Better Health Greater Cleveland, which has many of the providers, those patients that are seeing those providers, there is some significant improvement in the care processes. We're measuring outcomes, we're sharing best practices, and we're improving the care. There is not a Metro Health group, but there's the old Kaiser group does an unbelievable job in controlling hypertension, better than any other organization that we measure in Cuyahoga County. There are folks who do incredibly well on diabetes care and much better than others. And when we look at the sharing of this type of program, we've lifted up all the care and all
Across the entire region.
Right, and the vast majority of these are middle class insured folks. But let me give you a concrete example of how much we can do at significantly lower cost. So Metro Health did an experiment, a pilot, which was called Metro Healthcare Plus. Metro Healthcare Plus was the Medicaid waiver. It replicated basically what the Medicaid expansion, Obamacare, is. And we did it now, we've been doing it for a year. We have 11 months under our belt. The actuaries came and said to us, this is the cost that, based on actuarial data, you should be spending per patient per month. We're going to pay you on a fee for a service schedule, on a widget type schedule. But if it goes beyond that, we're going to take the money back. So using the clinical home care model, the medical home care model, we began taking care of these patients. And the wonderful and beautiful part is we've had them in our system. So we literally have 5-10 years of clinical data when they were uninsured. They're still in our system. And now we actually can see how John, who was uninsured, did when he became insured. So we ended up stabilizing for the past 7 months at $150 per member per month, lower than the actuarial numbers. For 28,000 people, that is $50 million less a year than would have been spent normally. Clinical outcomes, we know from care processes, they got much better diabetes care. So they saw the podiatrist more, they got the ophthalmology exam, they got the laboratory results, all of these. From actually outcomes, their hypertension was improved so that more of them were in control. Their diabetes care, which was astounding to get these kinds of results in 9 months, we had a 30% improvement in the number of people who became in control of in diabetes care. And we spent a lot less money. So what we saw was that we provided them significant increase in outpatient services as they came in. At times, 4 times the amount we would give an insured patient. The end result, significant reduction in emergency room visits, significant reduction in hospitalizations for an 11-month period. So we know this can be done. Does the payment system have to be changed? Yes, but I would also say one thing. We're not victims here. We have the ability to challenge the insurance companies and say it is time to move towards risk. They don't want to do it because they don't think we have the facilities to manage it, and we don't want to do it because we don't have, I would say, the courage to flip the switch on this.
Marty, a bit of a gauntlet there.
No, I would absolutely agree with what Dr. Boutros is saying, except where I would disagree is that, as a provider-owned plan, our system is at risk because what we collect in Medicare premiums and premiums from employers is all the money our system's going to get. If I begin to tank financially, it affects Summa Health System. It doesn't affect my shareholder equity. And so we are at risk as a system. We have been at risk, and I think that's the beauty of the provider-owned plan model, is we're both the financing vehicle. We collect the dollars and generate the data and informatics and systems and provide that support to our system. So we believe provider-owned integrated systems that have a health plan are in a much better position to move forward into this brave new world. Mm-hmm. And of course, I mean, Eric can speak to that from his experience at Geisinger, where they became a national model in this area.
Mm-hmm. Yeah, so I'm going to just step back for a second. So again, it's important to save money, it's important to drive quality, but I think what we have to think about is where does it start? And so I think in what Dr. Boutros is describing, it starts with you and a primary care provider. It could be a doctor, it could be a nurse practitioner, it could be a physician's assistant, but it's got to be somebody who knows you and knows your family and is willing to, take on some level of responsibility. So, this whole conversation about Medicaid expansion and expansion of, coverage, and that in and of itself isn't going to be enough to get to the sorts of numbers. And it's not the numbers, it's the outcome. It's what that means to people. It's not that, it's nice when you get all your diabetic things that you need to get done, but the reason you want to get them done is so you don't end up with blindness, you don't lose a limb, you don't have a stroke, you don't have a myocardial infarction. That's the reason to do all these things, and we know what to do to help people. But the misconnect here is we don't have the right number of primary care providers. We don't have people connected to primary care providers. We're not incented to train primary care providers today. And so, again, insurance and expansion is just one piece of what's a much more complicated equation. Because without that piece, you're not going to be able to get those good outcomes. If you can't go see a primary care physician, where are you going to go? You're going to go to the emergency room. And that's what we have to stop.
By the way, have we seen any impact yet on emergency room visits from what you at your institutions have been attempting to do with accountable care medical homes? That's measurable.
So we've seen across Better Health Greater Cleveland, which is across all our health systems, we've seen an improvement in ED visits. We've seen an improvement in hospitalizations and how many millions of dollars were averted. You need to ask Randy Siebels to talk about this. I don't remember all of that. But we're early on in the process. You go to folks like CareMore in California who is a Medicare Advantage plan. And they can show you some really extraordinary outcomes, extraordinary patient satisfaction, and amazing healthcare outcomes. They have, for example, 70% less amputations than the national average for diabetes. So people walking on limbs who otherwise wouldn't be. And are saving, by the way,
So,
an average of $5,000 per patient
Wow.
per year.
so there's reason to hope, but at the same time, this is balanced out against nipping at the edges and worrying whether the support structure is going to work fast enough, i.e., where are all those primary care doctors who actually, why would I want to be a primary care doctor when I get paid a third of what a neurosurgeon might get paid? How are we training enough primary care doctors in this great medical mecca of Cleveland, by the way,
Providers.
to keep up?
Providers.
Providers,
Providers.
okay, go ahead, because I know you're going to go there.
Well, no, I mean, it's again, it's not just physicians.
Right,
It was said earlier, it's the team. So, I mean, again, there are wonderful nurse practitioners who can do a whole lot of care and who can really aid in this process. So I think we've got to be smart about where do we allocate resources? How do we get people out there to be able to take care of all of us?
do we have the labor pool in Cleveland and Akron to support the healthcare needs of the population here?
I think if you asked me today at the clinic in terms of the population that we cover, we do have an adequate primary care base. We've recruited aggressively to build that base over the last 3 years. With regard to the training issue, I think the sad truth is that very few of the kids coming out are choosing to go into primary care. I was at the clinic for 16 years, left and came back. The history of the clinic is that the applicants to the internal medicine residency program all want to be cardiologists and gastroenterologists. That's why they come. And so we have begun, in fact, as we interview candidates, to try to selectively identify some kids who ultimately want to go into primary care careers. But at least at our place, we're not training enough. From my perspective. And part of that's the hidden curriculum, in fact, in medical schools that they receive as they're making their career choices. And some of it relates to the perception that it's onerous work, a lot of paperwork, and the compensation isn't what some specialists make.
And we're practicing in a not the most effective way. We're having physicians, primary care physicians, practice at the bottom or the middle of their license. They're doing things that other people could do. And so I use an example of my brother, who's a nationally known ophthalmologist who sees 100 patients a day. And people say, that's impossible. How could you see people that quickly? He literally has 7 support staff that work with him. The patient gets so much attention. What my brother does, and the thing he will never go away from, is he will do the fundoscopic exam that he must do on every patient before they leave. At the volumes that my brother has been doing them, he literally spends less than a minute doing half a minute on one eye, the other half a minute with the other eye. He actually gets to talk to that patient now for 4 minutes. Okay, real communication, has all the data before him, has already seen it, doesn't have to do anything. He's now practicing at the top of his license. He's not collecting each piece of data. He's not doing all of that. And in primary care, I can tell you is that on average, the adult, the Medicare patient is seen by a primary care physician for 7 minutes in care. All that other time is used to collect data, doing other things.
But what you're also implying in this is that we should be prepared for a shift, a little bit of a change in relationship. You know, everybody wants to love their doctor and talk to their doctor forever, but maybe that's not the greatest thing. Maybe, in fact, we'd get better care if we accepted and wanted to have our care primarily delivered by a nurse manager, a physician assistant, and save the doc for the hot and heavy stuff.
Yeah, so again, we're not making a value judgment of whether one is better than another. I think the challenge I'm bringing forward is these are highly trained professionals. And so in the same way that we want physicians practicing at the top of their license, I can assure you there are wonderful nurses in each one of our systems who are able to do all sorts of great care for people. And I think the challenge for us as the larger, broader environment is how do we make sure that that happens? How do we best position people for success? I would argue we don't have enough primary care providers and or doctors. I think there's places in Cleveland where we have plenty. And I think there's places in Cleveland, based on people we see every day in our emergency rooms, that don't have primary care providers and can't find them. And I can assure you that as an East Sider, if you head out east and you head out towards Geneva and Ashtabula County, you will be quite challenged to assure that you have adequate primary care coverage 35 miles away from where we sit. So again, part of the challenge is ensuring we've got the right people in the right place to take care of everybody. And, again, is that our responsibility? How do we want to drive that? What if it's you driving on I-90 through Ashtabula County tonight? And so these are provocative questions that don't have easy answers. But, again, if you're a medical student and you're looking at, that was called it was the road to success when, I was a little bit younger. It was radiology, ophthalmology, anesthesiology, and dermatology. By the way, none of us are any of those, which is probably why we're sitting here tonight. I'm not sure the road to success is quite the same road, but we need to align the incentives. So if you want people to do something, let's make it possible for them to do that. Pay them fairly to do that. Again, it goes back to how do insurance companies reimburse? How do we drive wellness care rather than sick care? If you don't go upstream and do that, well, then people are going to continue to get sick, and then we're going to be doing what we do, which we're quite good at, by the way.
At the same time, and I fully appreciate the edges of the region and the lack of enough care providers out there, but right here in the urban environment or the close suburban environment, we have historically also had a problem with access. We've been referred to as the medical mecca of the world. How ironic. And, that might be another hour-long session at some point, but is affordable care and healthcare reform actually yet improving access to care? You're showing me that in pockets it's improving quality and value. I do want to get to cost. You've shown me in some of the pilot programs, you're able to reduce cost, raise quality. Is it truly improving access? Yeah.
It's just begun, so it's too early. But let me give you another example. We decided to start a school-based clinic, not nursing, not a nurse's office, an actual clinic. Young man who has been coming to our emergency room, or happens to be at this elementary school, had 78 asthma ER visits in the year prior to us going there. We saw him more than once a week. First, I don't know what kind of care that is. I don't know if it can fit the definition of care. I honestly don't. I wouldn't. It wouldn't fit my definition of any care whatsoever. Okay. So he had this going on. Our system didn't recognize, even with the frequency, that this kid wasn't tied to a primary care physician. Gave him 78 referrals to one of our centers. Every time he left, where do you live? He lives right down from our Broadway facility. Okay? Go there. 78 times after discharge, he never showed. He has not, since we started the school-based program, we've seen him in the school. he's not had an emergency room visit.
Because you brought the health care to him,
Exactly.
which is sort of Dr. Welby, by the way. Let's do a throwback to before you were born, Akram.
Not exactly.
I just think there are a lot of barriers, social barriers, that if we're going to get the care that we're talking about, no one else is going to remove it. The healthcare system needs to remove it. Because if we're going to be accountable for the outcomes, we're not going to get there without removing those. We break down the populations that we have in low risk, and the healthy, and that's about 60% or 70% of the population. And the current healthcare system works just fine for them. You don't need to make major changes in it, just behavior modification, maybe lifestyle and that kind of thing. We have the rising risk, and then we have the very high risk. Our very high-risk patients, 10% of our Medicaid and dual eligibles, spend $129,000 a year at our facility. 129 cost $129,000 a year of payments for those populations that we've received, compared to $19,000 for the middle population. And the fastest way to go from rising risk to high risk, get a cognitive impairment, get depression, and the patient will move up from rising risk to high risk. Do we as a healthcare system really do well with that? We don't address it.
And that is the aging population that we are facing. Marty, I'm curious, is that why you talked about morality in the insurance business?
Yeah, so I knew you were going to get me on that. I should have never said that. So this is strictly my opinion, but a lot of what we've been talking about in terms of access is really kind of coming at the tail end of the healthcare reform law. Because if you think about it, it was passed in 2010. Here we are in 2014, and we're starting to see a little bit of development of the ACOs. I loved Eric's analogy of we're nibbling at the edges on care delivery. We're talking about access and beginning to address that. What's happened the last 3 years? Well, my biased view, if you look at what healthcare reform was really about, besides accessibility, and I still don't believe it was about affordability, for some people maybe it was really about three things. It was about instilling a sense of morality into the insurance industry because people said we've had enough with insurance companies refusing to cover people who are sick. I mean, does that make any sense? Or taking children who have pre-existing conditions and refusing to cover them. Does that make sense in a healthcare system in the wealthiest country in the world? Or doing things like not covering preventative care, but paying for catastrophic care. Does that make any sense? And so I think people around the country began to say, we've got to do something to instill a sense of morality into the insurance industry that says, we're not doing this right. And to hold the insurance companies and the insurance industry accountable to flip that model. The second piece is about transparency, because the Accountable Affordable Care Act said, you as consumers really have no data and information on how to select doctors or hospitals. Now, fortunately, we have great health care. We have the best health care in the world here in Northeast Ohio. But you still get more and better information on how to select a car or how to buy a TV than you do on how to select a doctor. Most of you select a doctor based on either what your doctor says to do or what your friend or neighbor did because they had a good outcome. They had a good outcome. You don't know if anybody else did, but they did. And the third piece is about addressing this whole issue of accountability. And that's the piece we're getting to now, which is holding insurance companies, doctors, hospitals, what I lovingly call the industry, the healthcare industry, accountable for the value and the cost of the care that we're delivering. So I think the Affordable Care Act is about morality and about forcing our industry to start addressing the issues that we've not addressed in the past.
Show of hands, has anybody ever attempted to find a physician based on some objective data of quality that maybe you searched for on the internet? You have? Did you succeed?
Who knows? I mean, I looked at best doctors in America. I say,
Right, and so that is a highly marketed thing, and I think you probably paid a privilege to do that, is that
So
right?
with all due respect,
Right,
you
go
may
ahead.
want to look at what the criteria is for best doctors in America, because the last time I read the statistic, hospitals advertise that they're one of the best 100 hospitals. There's something like 1,100 best hospitals in the United States, depending on what the criteria is and what report you're looking at and this kind of thing.
Which gets us into that idea of how should we today, all those folks in the audience, begin to try to compare quality, and how do you see this evolving in the near future, over the next 5 to 10 years, as informatics gives us so much more information? Think about the answer to that question, because in reality, in administration and healthcare, you guys know how your doctors are doing. You have been held more accountable than ever. And I see Tom Chem in the audience, and when I went from healthcare to academia, I lamented a little bit that we are not quite as held accountable. Oh, don't quote me on that. Can you cut that tape? As these docs and the hospitals. So you know how docs are performing, and we're moving in that direction. So help us answer the question of how do you get the doc who's got the best outcomes? How do you get the hospital? It's probably on your card is your question.
We have handed in a lot of cards.
Can I see some of those cards so that I can start to do? But let me ask you to respond.
So I'll start and then ask you all to chime in. I think one of the things that we have been very remiss as a healthcare industry in doing is doing what every major business and industry in the United States does, which is to establish uniform measures of quality. In fact, quite the opposite. We've done a good job of finding lots of excuses on why all of us have different quality, because his patients are sicker than his patients, and the risk profile of my insurance company's patients are sicker than Aetna's patients. And so instead of coming together, as most industries do, and say, we're going to establish standardized, measurable, quantifiable benchmarks and share the data across all of our organizations and share it with you as consumers, we as industries have said, oh, data and information is a competitive advantage, and we're going to keep it to ourselves. And we're not going to share it with anybody because we believe it gives us a competitive advantage. And until, I think one of the things that this change, transformation, whatever you want to call it, healthcare reform is going to do is drive all of us collectively as an industry to begin to respond to you, because you've never asked for it. We've not given to you, but you've never really asked for it. And so as consumers get higher deductibles, higher co-pays, you're paying for things, Eric and I were talking about this earlier tonight, you're paying for things out of your own pocket, you're going to start saying, wait a minute, time out. I want to know who's going to give me the best quality at the lowest price. And I want standardized measures, and I want to be able to do with my care what I can do with a car.
So I needed a doctor when I came here to Cleveland. So I went to Better Health Greater Cleveland, and I said, I want a Metro Health doc. So I narrowed that down to the doctors who are on this, all the primary care physicians, and happens to be our entire primary care faculty is in it. And I said, I want to see who has the best outcomes. And I got a choice of 3.
And that is on the web, by the way, Better Health Greater Cleveland.
So I got three docs. I honestly, I wanted a woman because I live all with women at home and I listen much better to women. So I decided to continue with that. And I also wanted somebody who wouldn't care that I was the CEO of the health system. And I literally interviewed 2 people because they were both women. And one could care less who I was. And she was going to tell me what to do no matter what. And I picked her. So that was my interviewing process for picking my primary care physician.
That's great information.
So I would comment perhaps a little provocatively that I think all of this is very, very important, and we certainly should be encouraging patients to be active participants in their care, to look for these quality metrics that are indeed publicly reported. But I think that those are the floor. This is only the beginning, and I think that when we look back 10 to 15 years, that quality science will be a very different discussion. And for me, certainly I want to pick physicians who perform well around blood pressure control or glycemic control, but there are intangibles that do define superior care that I think we still struggle as an industry to actually measure, and we haven't yet reported, and that is going to be the challenge for us as healthcare professionals to build that out for consumers as well.
You know, somebody asked the question that implies that we're not really, we're not getting to how the Affordable Care Act is relevant to what we're talking about. And yet I would say that
We wouldn't be having the conversation
Right.
without the Affordable Care Act. So I would argue everything we've just talked about, we're talking about. If it didn't exist, we'd all be home with our families having hopefully red wine or something. But, you know, the Affordable Care Act has driven a lot of innovation. So, I mean, you can love it, you can hate it, you can, you know, at some level, I'm agnostic to it. I'm literally apolitical to it. I don't care much about it other than how it drives us to do something different than what we've done to get better. And I think it has forced us to be innovative. I think we're seeing cuts. We're having to become more efficient. You're going to see more transparency. So the answer to your question is, you know, there's some data now, but there's going to be more data in the future. You know, you've got to become really engaged. You've got to become really smart participants. And you can be. I mean, I was a very, very busy clinical doctor. And, you know, I wanted my patients to know darn near as much as I knew, because the dialogue you could have with them then was so much more rich. And we ended up with much better outcomes. This is driving that function. This is forcing us to do things different than we would have otherwise done. So we're on a path that's changed forever. We're never going back to where we were. Again, like it, don't like it, hate it, it doesn't matter. It will never be the same. And it shouldn't be. We need to get better. We need to challenge ourselves. The industry needs to challenge itself. Insurance needs to challenge itself. We can never be satisfied that we're as good as we could be. The metrics are never going to be good enough. I want you to feel incredibly good about every visit you have, wherever you go. Whether it's my system, it's his system, or it's his, it doesn't matter. The better we all get, the better we'll all have to get. Consumers win in that. Patients win. You'll get better care.
So I think to tail off of that comment, one of the things that has fascinated me as this has rolled out and as it has tried to drive quality and cost is all of a sudden there's this discussion about how are we going to better engage patients in their care? How are we going to drive decisions around wellness? How are we going to, the term is activate, patients to be partners in their care rather than passive, reactive recipients? And I think that would not have happened had we not had to deal with the Affordable Care Act.
So the summary comment I always make when people ask me about that is I say, to the question earlier, what's the difference between now and the 70s? The Affordable Care Act, whether you like it or not, created a burning platform. And that burning platform is why you're here tonight, and it's everything that we've talked about, because as Eric said, 5 years ago before the Affordable Care Act, this would have all been kind of philosophical, theoretical discussion. It's real now. The Affordable Care Act made it real.
So think about what was just said. We're talking about patient engagement. It is absolutely the holy grail of healthcare reform. Okay? For the entire history of the healthcare system in the U.S., we've been satisfied with the concept is I gave the patient the referral. My responsibility ended when the patient came in and I said, you need to go see someone else. The lawyer said that's not good enough, so they said you have to send them a letter 3 times. Still, our responsibility ends when I've given you something. It's as if I've said the lesson plan, you didn't learn it. You know, I'm the teacher, I said the lesson plan, you didn't learn it. Today, we're not talking about that anymore. We're talking about activating patients, because our job doesn't end with giving them the referral. Our job certainly wasn't good for that asthmatic kid, because we gave him 78 referrals. You would think after the 77th time he would go, didn't go, and we had to do something drastically different to both get him care, and actually activate the family. I'll tell you the second part of that is he was uninsured. He qualified for Medicaid. Didn't know that, his family didn't know that they qualified for Medicaid. Not only did he get the Medicaid coverage, his mom and dad came to the school clinic. We qualified them for Medicaid and scheduled their first visits. So there's a lot of side benefits when you're targeting one individual. You actually end up sometimes impacting an entire family.
So I guess I would take it one step further. I think it's not just about activating individual patients. This has spawned the discussion about activating populations.
And address that in this sense. I'm seeing on some of these cards, there's a lot of politicization still, and a little bit of anger that we're not quite, again, talking about the Affordable Care Act enough. I think what we need to do is drive it down into the patient-physician relationship, that if it is changing, how should it be changing? In other words, you're talking about some very concrete changes at an institutional level that is a little bit of inside baseball, I think, for a lot of people. I love it. I'm fascinated by it. The curtain has come down. You're talking about what's going on behind the curtain. But a lot of people are not feeling, hearing how it's either going to impact them or not. For example, at Metro, before I left, I remember the whole point of the use of electronic medical records of the medical home was a doctor would get a little ping on their computer if so-and-so Joe Schmo did not come in for their eye appointment in a timely basis. Akron's probably pulling one out right now.
I'm pulling my chart out.
Okay, and in fact, somebody would call you and tell you it's time to come in here and take care of yourself. Now, granted, I'm healthy, I don't necessarily get those calls, but I'll bet there are people in the audience right now who have chronic disorders, whether they're diabetes or heart. And are you ready to say, if you're not getting that kind of care, you should be getting that kind of care, because that's where the institutions are moving, and maybe you're not with the right institution or the right doctor if you're not getting that kind of care yet? Can you say that?
Well, you're not getting the right kind of care. I'm not sure if that's the sole criteria for it.
Okay.
Okay, but this is my medical record. I have my lab results, my messages, my communication back and forth from my doctor, my appointments, my medication, my health reminders. I have 3 that I have to complete this year. And by the way, you will be happy to know one of them is a hemocult blood. Okay, so just so you know, it's right there, hemocult, I have to do it. Okay, and it has my health summary. Okay. I also have a blood pressure cuff that's tied to my computer. I have it programmed that, and we were titrating my blood pressure medicine. Every time I came in, it registered my blood pressure and actually was sent to my doctor for her to keep records. I have seen her twice now. The vast majority of the titration of my blood pressure medicine was done electronically. I didn't have to go, she's in my hospital, I could have seen her, didn't have to see her. When I was practicing internal medicine, you would have had to come to see me at least once a week or every 2 weeks until we titrated.
So can I jump in?
Yeah,
I've got to jump in.
that's great.
I've got to jump in. So I'm on your side for a minute, so pretend, I know it's hard to like an insurance guy, but pretend I'm on your side. You heard what, I'm impressed with that chart, except I'm a consumer. So if I go to Metro, I can access that great chart. But then if I go from Metro to the Cleveland Clinic, I can access the Cleveland Clinic's great chart that doesn't talk to Metro's chart. And then if I go to UH's chart.
Not true. So
We can talk. It's difficult, but
we
can talk, it's difficult.
Different languages.
So today, we actually, between the clinic and Metro, share all the data on Epic, because where it happens to be, but here's the other thing. We just did Epic Anywhere, and any physician in the entire country, if you give them access to your chart, they will go online and download or look at everything that happened to Metro.
For anybody who's on Epic.
For anybody on, yes.
Not everybody's on Epic. And, oh, by the way, if you have SummaCare, we have a great chart at SummaCare for you as a consumer. But if you switch from SummaCare, your employer does, to MMO, none of the SummaCare data goes to your MMO chart. So now you have an MMO chart, and then next year you go to Anthem and you have an Anthem chart. Do you get my drift here? We've got to figure this out. And to the question of what impact is the Affordable Care Act having on you, how many of you are covered by an employer-sponsored health plan? Keep your hands up. How many of you are covered by Medicare? Keep them up, okay?
Keep the hands up
And
with
the
the
employer-sponsored too?
employer-sponsored.
Okay, so one of the impacts of the Affordable Care Act is your costs are going up this year.
Right.
You're all going to pay more
Right.
under the Affordable Care Act.
Because the cost of supporting those now covered under the Affordable Care Act,
And the government's added about 14 to 16% taxes onto the premium to pay for the infrastructure for the systems that's not working so well.
So I want to come back, I can't help myself, but come back to the issue of patient engagement and patient activation, because it's not just about what health systems and caregivers and insurers have to do. We have a system called MyChart, which is a way to communicate with people, with your caregiver. Only 40%, despite massive campaigns, of our patients are signed up for it, and only 17% of those 40% actively use it.
So, David, let me challenge you for a second, if I can continue my, my point about everybody's got these charts. Epic may be doing some good things, but if you look at the credit card industry, what the credit card industry figured out back in the 1980s was, you all remember the day when you went to the store and you had your credit card and you had to wait while the clerk called your bank and gave the number and then took that thing and went and gave you a carbon copy, and you go to the store and pray that you didn't get behind somebody who's using a credit card. So what the credit cards figured out? They figured out that the information isn't the competitive advantage, it's the services and the quality they provide. So the credit card companies all got together and create a master system that allows you or me to go anywhere in the world today and within milliseconds swipe our card, no matter what bank it's drawn on, goes through a master information system, and it's approved like that. And now you pray that you're not behind anybody who's paying with a check or cash,
That's right.
because it takes too long. We've got to get there with healthcare. We've got to get the data and information, whether it be Epic or whomever it is, across the insurance industry, across the hospitals, the doctors, pharmacies, everybody linked together so it works like the
So I'm not
credit cards.
disagreeing with you on that. The point that I was trying to make is that, albeit imperfect, and that we're having systems that don't talk to one another, some of those systems allow patients to communicate with their caregiver, and we ideally need patients to be much more in the game about signing up and taking responsibility.
So we have a campaign that's going to be starting soon about, I think we're at 36% of our patients are signed up for MyChart, and by the end of next year, we want to get to 80% of our patients. And so we're going to try this really cool thing. Most of the patients we believe who are not signed up with MyChart just have a hard time with computers. It's not their thing. And they don't have a 14-year-old who can help them. We're going to hire high school kids who are going to help people sign them up. And here's the interesting thing. They're going to adopt a grandparent. They're going to actually adopt the person that they're helping. And so when the person is having trouble, they're going to call that kid.
the 14-year-old.
The 14-year-old high school kid who's going to be able to walk them through it. Because frankly, my IT folks are not as good as the 14-year-old.
Right.
And they get paid a lot more than minimum wage. So that's just an, again, but to David's point of view, without the Affordable Care Act, none of this would, 3-4 years ago? No. When I was faced with putting the electronic medical record 6-7 years ago, I said, how much is this going to cost me? Can I afford it? And at the time at my organization, I said no. End of discussion. That was it. And today, that hospital has an electronic medical record because of the ACA.
So if you depoliticize the issue, because one of the questions coming from somebody out there is, well, why do so many people hate the Affordable Care Act besides, hating the administration that brought it about?
Costs them more money.
Costs them more.
It's costing, and it's change. It's simply change, or fear thereof, no?
Well, frankly, it's not changed, because the vast majority of people in this audience I would dare to say, has not experienced negative change by the Affordable Care Act. I spoke to a group of 60 or 70 elderly folks in Florida, highly affluent people, okay, could afford to pay cash for all their health care. They were absolutely fearful that they're not going to be able to see their doctor when they wanted to, the way they are used to. That was their entire thing about, and that was my talk about the Affordable Care Act. They said, yes, but if you clog my physician with all these other people, I won't be able to go see them.
Some have argued that the reason people are so polarized about the Affordable Care Act is because the unknown. It's not the change, it's all the unknowns that are out there. And it's going to put tools and responsibility into the consumer's hands that in the past they've not had. So the one thing, on the one hand, Dr. Boutros was correct. We said for years, you go to the doctor and the doctor tells you what to do, and it's a one-sided approach. Now we're engaging the patients. But remember when Henry Ford came out with his cars, Model A cars, he said you could have any color you want as long as it was black. It was easy. You could buy a black car. Well, then GM decided to start putting colors in, and now you look at what we have, and people scratch their heads, and they hate the process of buying a car because there's way too many choices, and they've got to get involved, and they've got to study it. And some have argued, I don't know this is legitimate, that it's like in the old days in healthcare, you could have any color of healthcare you want as long as it was black. And now we're engaging you, and the uncertainties, the use of technology, all of those types of things are causing people unrest.
So, another part of this is, this is what we live and breathe every day.
Yeah.
We understand, and by the way, we don't completely understand it, and we've got lots of questions too. Not a day goes by that my mother, who just turned 80, doesn't send me, so she'd be one of the people who's very savvy at email, and maybe we can sign her up to help the folks at Metro, but, an email with something crazy in it that she says, is this really true?
From AARP.
Well, I'm not, no, we're on camera, so we're not going to put jabs at good organizations.
Okay, that's fine. I have an 87-year-old mother-in-law, and she sends it from AARP. Sorry, go ahead.
So the challenge is truth, sort of truth, fiction, really fiction, and political fiction for somebody else's gain. And, it's very hard if you're not living this and really understand it to know which one of those it is. Yeah, my mom's pretty savvy. I mean, she's a smart woman, and yet, I want to tell you, she's really confused by all of this. So I'm not surprised that A, you're mad, B, you're confused. What is the truth? Do you believe us? Do you believe, these sources seem legitimate, but gosh, it doesn't feel quite right. This is really hard for folks, Eileen, seriously.
Yeah.
And so I think that's a piece of it. So again, I think what you've got to try to, is this political? Is there somebody that gains something through putting this sort of information out there? It is tough to sit in your seats.
Or said differently, nobody ever believes anything they read on the internet or in the paper until they read it on the internet or read it in the paper.
And it could impact them.
Yeah.
So I guess I have an optimistic view. The healthcare system in America has always progressed towards the goals it had. For a very long time, many, many years, for the past 50 years, we wanted to take care of people after the fact. We didn't want people to die from accidents. We wanted to relieve pain. So we've spent our entire lives doing that. The reason that Saudi prince come to Cleveland is because there is no other better place to get your sick care than with our organizations, okay? So that was the goal. We did it incredibly well. We became the best in the world for it. Very high cost. Now we're changing the paradigm. And we're saying we're no longer going to be measuring outcomes by when you came in with stage 4 cancer, how many people survived, but we're going to actually look at how many people were prevented from getting cancer, how many people were prevented from progressing and the like. I have absolute, unadulterated, complete faith in the healthcare system in the U.S. to succeed in that.
Agreed at this table? In your lifetimes? Ooh.
Yeah.
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 So we are coming to an end. It's 4 minutes to go. And so I want to give each gentleman an opportunity to round this out and have a take-home message that those of us in the audience can remember from tonight. Start at the end. I started there at the beginning.
Be active participants in your care. Ask questions. Do your homework. Go prepared. You have a right to demand communication from your caregivers. And you have a right to demand quality and to know how we do, how your caregiver does around quality. I guess my last reflection about the Affordable Care Act is that I think it's only the beginning. And I like to liken it to the passage of Medicare back in the 1960s. That was a journey, and it's been an iterative journey over nearly 50 years. And I think the same thing is going to happen with the Affordable Care Act.
So I would say, in addition to that, think about the barriers to your own health care that are not just the doctor relationships. What other things are getting in the way of you getting the best health care possible? Because the healthcare system is going to begin to address that, because it is now about giving you access, engaging you, doing a lot of these things. So when you go to a physician's office, let them know if that transportation is a problem. Let them know that 70% of our patients immediately after they leave the hospital or a doctor's office are confused about what the next step that they have to do is. That's research, 70%. So if you need to tape record something, if you need to write something down, if you need to come back and ask a question, you got to determine what is the barrier for you to getting the most excellent health care, and you got to tell us. If we don't ask you, you got to say, I need you to solve this problem.
So I would say regardless of whether you're in favor or opposed to the Healthcare Reform Act, that heard somebody speak a couple months ago, he's a national healthcare policy expert, said that left unattended, if we didn't have PPACA and what it brought to us as a terms of a burning platform, that our healthcare in the United States, healthcare costs represented the single largest security threat to the U.S., more so than terrorism, more so than anything else, because it would bankrupt the country if we let it go. It'd bring our economic system down. So we're going to take care of that. We, the healthcare industry, are going to address that. We have to address it. At the end of the day, don't get caught up in all the acronyms and the politics and all that. Focus on the fact that at the end of the day, everybody at this table, regardless of what system they work at, are here to support the fundamental relationship between a patient and their caregiver. Mm-hmm. And you want to find systems who are committed to supporting those relationships and not get bothered by all the static that's out there.
Yeah, so I agree with a lot of the comments that have already been said. You know, fear is paralyzing. And so we don't want to operate from a place of fear. I think, each of you should go out and, do the political battle for those that bring forward what you believe in. From a standpoint of the Affordable Care Act, I think in the end, we will end up with better care. We'll end up with higher quality care that's more transparent for less cost. Ultimately, today, I think that's a challenge. I think there is more cost, and I think you're feeling that. And I think it's disorganized, and it feels disorganized, and I think it's disruptive, and it feels disruptive. But, you know, what do I believe? I believe out of that chaos, 5 years, 10 years from now, we're going to emerge with better health care. I think we are fortunate in Northeast Ohio. We have great health care. But I agree with the others. I want you to be advocates on your own behalf, on your family's behalf, to ensure that you get what you deserve, which is that in each and every encounter, the very best for you and your families. You know, my goal would be for each of you and for everybody, no matter what letters they have after their names, no matter who they are, no matter where they live, no matter what their background or their ethnicity, that they would get the same care I'd get, my family would get, and that I might even give Marty as an insurance guy, because I do like him. I can't want more for you than that. That should be the expectation.
And I am so grateful, and I think you all need a round of applause for the honesty